So, ooh. Okay, so today we've got two presenters for our lecture, or our Wednesday lecture. The first one will be Stephanie Heeney, who is our outpatient pharmacist. She came to us after working a couple of years in PharmD in the programs of heart and lung transplantation. And before that, she did her PY1 and PY2 years of solid organ transplant residency at UNC in Chapel Hill. And prior to that, she graduated from her PharmD at UW and pre-pharmacy studies at the same institution. She's going to be followed by Gina Bliss, who is also a pharmacist who works here at Yale. She is a cell compounding consultant at the Department of Pharmacy at our hospital and co-chair of hazardous handling committee for the Yale system, besides being the CEO and founder of Penn Family Pharma Consulting, Bliss Compliance Consulting. She obtained her PharmD at the University of Sciences in Philadelphia and a post-baccalaureate program at UPenn. And prior to that, she was at Rutgers for her BA. So thank you very much for giving this lecture today. And I think that, Stephanie, you can take it away now.
All right. Let me just bring up my slides. Okay. So we thought we'd do something fun for this last session. It's a little different than what we've been doing week to week. I am taking a couple of questions that I've received from patients since I've come here to Yale in the clinic setting. All of them are kind of related to reproductive health in some way or another, and talking you through the data that I'm aware of in solid organ transplant and how I answered those questions for patients. So I'll talk a little bit about the impact of sirolimus on male fertility, the use of mycophenolate in males and females, and the resulting fetal risk. And then I'll briefly hit on our variety of contraception options and talk about drug interactions and some adverse effects in there as well. So our first case, and for all you heart transplant people on the line, these are questions we got in clinic, but the acronyms or the JM doesn't actually refer to a patient. So don't spend the whole presentation trying to figure out who I'm talking about. I made them up, but JM is a 34-year-old male, SAS with heart transplant 3 years ago, and he presents to transplant clinic for his annual studies. He's really excited to share that he and his significant other are trying to start a family. His current immunosuppression regimen consists of sirolimus, 2 milligrams daily. He was converted from a calcineurin inhibitor about a year ago for renal dysfunction, and mycophenolate, a gram BID. Today's question is, are the medications he's taking going to make it more difficult to conceive? So there are quite a few similar studies out there, but this I felt was the most clear. This was a retrospective observational study of male kidney transplant recipients that were of reproductive age. And they split patients into two groups. Group 1 received sirolimus throughout their post-transplant course, and group 2 never received sirolimus. And what they found is the patients who received sirolimus had a significantly reduced total sperm count, decreased proportion of motile spermatozoa. There was no difference in testosterone levels, but there was a reduced pregnancy rate. So the mechanism is not entirely clear here, but it's thought that mTOR is also a key regulator of spermatogonial proliferation. So it makes sense that if we're inhibiting that, we may inhibit sperm production. And there's a whole bunch of case reports out there of male transplant recipients on sirolimus that had difficulty conceiving. Some actually were able to conceive once they were switched back to a CNI, and some were not. So it's a little unclear what the preferred action would be. But to answer his question, yes, patients treated with sirolimus have reduced sperm count, reduced proportion of motile spermatozoa, and reduced rates of impregnation compared with male transplant recipients that are on a sirolimus-free regimen. And so he may have more difficulty conceiving on this regimen and may benefit from counseling from a fertility specialist, and potentially adjustment of the immunosuppression in the future if it's warranted. And he's got a follow-up question for us. He's heard that some medications can cause birth defects, and he's wondering if it's safe for him to father a child with his current immunosuppression regimen. To be perfectly honest, we don't have any data on sirolimus, but there is quite a bit on mycophenolate due to the fetal risk when female transplant patients take this, which we'll walk through. Part of the reason this is a hot topic is because the European Medicines Agency in 2015 put out a statement saying that sexually active men taking mycophenolate are recommended to use condoms during sex and continue to do so for at least 90 days after stopping treatment. Their female partners should also use contraception. So this is a pretty significant statement. And a lot of centers are asking if this is really necessary. So the data we have to support or not support this statement includes 3 trials. The first one I'll talk about is an NTPR study. So it's looking at our US transplant registry data. Because this is a registry study and the way it was done, it's all voluntary inclusion. So we don't probably capture everything with this study, but it's probably pretty good. And they found 152 male transplant recipients with exposure to mycophenolate. Some of them were heart transplant patients, so that was great. And these patients fathered 205 pregnancies, resulting in 194 live births. What they did is they took this NTPR data and they compared it to our general population from 2009 and said, were there different outcomes between these 2 groups? And what they found is that there was no difference in birth. Well, there were no difference in outcomes in general, but specifically no difference in birth defect rate. So we can see here 3.1% with the NTPR data and 3% with the general population. What's also important is that there was no pattern to these malformations. So the 6 malformations that were reported did not appear to have any sort of a pattern that could be linked back to mycophenolate. And then the second study, this is interesting. So this was a Norwegian registry study. And because of the way they did it, it was all kidney transplant, but they used both the renal registry and the medical birth registry in Norway. And theoretically, with all of these, they should have accounted for all of the births that happened and were documented as a transplant recipient, male transplant recipient, as being the father. And they looked to see which patients had documented mycophenolate exposures in the year that those babies were born, and compared babies that were born to fathers with mycophenolate exposure in that year and without, and found no difference in any of their outcomes, no difference in malformations, no difference in child weight, gestational age, anything like that. And this last study was another Norwegian study, so it came from the same registry. But what they did here is they took patients, they took patients who received a transplant and fathered a child, and they compared the children that they had after transplant to the children that they had before transplant. And there were no difference in malformations, no difference in preterm delivery or small for gestational age. There was a difference in preeclampsia. This is the first noting of this. And so it's not really clear if it's related to mycophenolate or the transplant itself or any other medications. And it was a retrospective registry study, so it should be taken with a grain of salt. But for the most part, I think with those 3 studies, we can conclude that in male transplant recipients, paternal exposure to mycophenolate did not increase the risk of malformations. And so for our patients, I do not recommend any change in paternal immunosuppression. There are still some European centers that are switching folks off. But as we know, anytime we change immunosuppression, we open patients up to the risk of rejection. And with the available data, I don't think that we have enough to say that it's worth risking that, since there's no data indicating that there's an increased risk of malformations with mycophenolate. So I'm going to kind of switch gears here. That was one of our male patients coming in asking a question. Oh, yeah.
Sorry, before the next case, I just wanted to clarify I wanted to pick your brain on a couple of questions, if you don't mind.
Of course, please do, Lavi.
So my first question is with regards to the sirolimus. Is there effect on sperm count dose dependent?
That's a great
Or
question.
trans?
I don't think we know the answer to that. And the other thing that could play into this that we don't have the data to support is time on sirolimus, and if the amount of time versus dose is what's causing the ability to reverse this or not. So I am not aware of any data that necessarily supports or that looks at that, I should say. But I think that it's likely that dose or time on the medication play into it.
Got it. And follow up to the next topic, which is the MMF.
Yes.
Judy, do you know why the EMA recommended that? I remember kind of going through so much of a hassle trying to do retraining and kind of education patients. Back in 2015, we went through all these hoops. Based on everything you presented, there's no data to suggest that we should be worried. And second part of that question is there any literature that might make us concerned from the rheumatological world where they use higher doses of MMF in their patients? I mean, I'm just wondering where this came from.
I don't know where it came from, and I did some digging as well. I think that this, at the time, those studies are a little bit newer. So I don't think that there was much data. And so my suspicion was that this was the most conservative path. But I've actually read it, and there's nothing cited. We don't know why it was necessarily included, but it was the reason that some of these studies were actually developed. So I think it was just a paucity of data at that point. In terms of higher mycophenolate doses, I'm not familiar with the data outside of solid organ transplant. So it's possible that there is some data out there on higher doses. There's kind of mixed information in terms of if mycophenolate even penetrates sperm cells. And so it's possible that, that this is a non-issue because it's not actually getting to the sperm cells themselves. But I don't know if the dose impacts that. And none of the studies that we looked at, they're all retrospective, they're all registry. So none of them had dosing in them. You kind of assume that they had them on about what we keep our patients on, but I can't even confirm that the studies I looked at had them on high doses. So
yeah, and then this whole thing about the MPA levels and how that interacts. But thank you so much.
Yes, no, thank you for the question. Everyone else, please jump in as we move along. I'm switching gears a little bit. So we had a female patient come in, and we've got a decent number of young female patients. So I thought this would be nice to review. SJ is a 25-year-old female. She's status post heart transplant 5 months ago, and she presents to heart transplant clinic for routine follow-up with her significant other. She's recovering well, starting to resume normal activities at home, and she remembers that inpatient pharmacist telling her about the risks of pregnancy with her current medications. She wonders if she should be on birth control and if there are any contraceptive options she should avoid as a transplant recipient. So I'm not going to spend a lot of time on this because I'm pretty sure this group understands that this patient needs to be on contraception. There's not a ton of data in the heart world, but in kidney and liver transplant, we know that fertility returns within months after transplant, even in patients that have amenorrhea pre-transplant. And we see that in the CF population and lung transplant. So one can extrapolate that this likely occurs in heart transplant as well. And we know that mycophenolate increases the risk of embryo fetal toxicities. So high rates of first trimester pregnancy loss, congenital malformations, and a variety of abnormalities. The table included below is a retrospective registry study of heart transplant recipients specifically and the pregnancies documented. And we see here a lower rate of live births in pregnancies that are exposed to mycophenolate, a higher rate of miscarriages, and a higher rate of birth defects, as we would expect to see. So for those of you who aren't familiar, the mycophenolate REMS program actually has a pretty decent patient brochure, and I've printed this out for some of our patients, and it kind of reviews the potential risks in a patient-friendly manner, and then some of the birth control options that are available. Obviously, option 1 is our most effective. I don't usually talk to people about vasectomies or tubal sterilization, but I do talk to them about IUDs. Now, our heart transplant team isn't necessarily prescribing any of these, but I do think it's helpful for patients to start thinking about what option might be best for them before they head over to family medicine and continue to get more information. IUDs, there's 2 different kind of categories of IUDs. The first one is the copper IUD or Paragard. And this one's got a variety of different mechanisms. It's been used for decades. The mechanism is still not fully defined, but we know that it has this foreign body reaction and it stimulates an inflammatory response. It recruits leukocytes and it basically creates an environment in the fallopian tube that's toxic to sperm cells. So it prevents viable sperm from reaching the fallopian tubes before preventing fertilization. It's pretty safe. We don't see any sort of elevated serum copper levels in patients that are taking these. But the big problem for us is there have been treatment failures reported in renal transplant patients. And the theory is that an intact immune system may be necessary to get this full foreign body reaction, which we think is part of the mechanism of this, this contraceptive strategy. So in 2005, AST put out a consensus report, and here they cited those 2 cases of failed copper IUDs, and they state that immunosuppressive agents decrease the effectiveness of intrauterine devices, and immunocompromised subjects using such devices have an increased risk for infection. So this is a big statement. And really what's cited is just those copper IUDs, but there is a whole other category of IUDs that we could be using. So the levonorgestrel IUDs, there's a variety of different brands that make them now. They last for different amounts depending on the brand that you use, and they work by releasing levonorgestrel locally. And this decreases endometrial receptivity to implantation and thickens the cervical mucus. Now, of course, with any sort of transplant patient that's immunocompromised, putting a foreign item into them, the theoretical risk is you could get pelvic inflammatory disease due to their immunosuppressed state. So what data do we have to support the use of these in transplant patients? We're starting to get more. I'd love for there to be more out there, but we've got 3 case series really that we turn to. The first one from 2012 is 11 solid organ transplant recipients, most of which are kidney, and they found no documented infections or unplanned pregnancies. In 2017, we got another case series of 6 solid organ transplant patients. We got 2 hearts in there, and they found no incidence of pelvic inflammatory disease or pregnancy. And finally, in 2018, we got 23 patients in this case series. It's the largest, it's pretty much all kidney. But what I've highlighted down at the bottom are 2 patients that actually received the IUD within the first year. So what we don't have in the literature is a lot of data supporting using these within the first year. But anecdotally, the last 2 centers I've worked at, we have used these honestly when a patient is able to lay flat for the procedure within the first couple months after transplant, because we figure the risk of an IUD outweighs the risk of an unplanned pregnancy. And I have seen no cases of pelvic inflammatory disease, infection, or unplanned pregnancy with these. So I'm a huge proponent of the levonorgestrel IUD. Now, if patients aren't interested in an IUD, which it requires a procedure, some patients aren't comfortable with that. Option 2 down here are less effective items, but still good. Has a lot of options for patients, and I think patients kind of get lost in here. And so I try to narrow it down for them based off of what we think would make the most sense for a transplant patient. The most common contraception by far are the combined oral contraceptive pills. So patients love these, but ethinyl estradiol is a known 3A4 inhibitor. It impacts CNI and mTOR metabolism, and then cyclosporin and tacrolimus inhibit phase 1 and phase 2 metabolism of the estradiol. So you have a lot of drug interactions happening here. For the amount of drug interactions that are happening, we have very little data telling us what happens when patients take these medications and what happens during that placebo week, that 1 week of white pills where they're not exposed to drug. So I'll give you what we have out in the literature, even though it's not a lot. This here is a case control study of kidney transplant recipients in Iran who actually received oral conjugated estrogen for like 3 to 7 days as a way to prevent bleeding around the time of a renal biopsy. So not contraception at all, but slightly related. And our 3 time points here, the first time was, when they were just on their tacrolimus, no estrogen. Second time was when they were on the conjugated estrogen for at least 3 days. And then third time was again off of the conjugated estrogen. And as you can see here, the case group, those that actually received the estrogen, had higher tacrolimus whole blood concentrations when they were on the 2 of them together. And then I'm stretching here, but we've got a case report of a 32-year-old female on cyclosporin for uveitis. And you can see here, I wonder if I pointer options, here we go. Okay, so you can see here, she was pretty stable on this 5 mg per kg of cyclosporin, had levels of around 100. And then she was started on the birth control pill and her level went up to about 250. This is an old case study, so they didn't get levels quite like we do, I don't think. The birth control was stopped. Her cyclosporin levels came back down. It was restarted, her levels go back up, and then it was stopped again. And so this is just an example of what we think probably happens when our patients are taking these oral contraceptive pills. I don't have a great sample with tacrolimus and oral contraception. If anybody would like to study that and put it in the literature, it would be much appreciated. But so I don't think that I can necessarily rule these out as an option for our patients, but I think we have to think about it. We have to think about the TAC level or the cyclosporin level and where they are in the cycle and how that's going to change. Because if we titrate it to when they're on the ethinyl estradiol, then during that placebo week, their level is probably going to drop a little bit, putting them at risk for rejection. There are options. So you can do continuous administration, skip the placebo week, skip the period, or seasonic, where they're getting a period once a season. It's not perfect, but those are options for patients that really like the oral contraceptive pills. The patch is another option. So, okay, Stephanie, what if we give them something that has a more continuous release of estrogen? Like, would that be better from a drug interaction standpoint? Theoretically, maybe, although the patch is still one of, you put one on each week and then you have a week where it comes off. So you still have the difference in drug exposure. And the ethinyl estradiol exposure with these is 66% or 60% higher with the patch than an oral contraceptive, because you're getting that continuous exposure. Because you have more exposure to estrogen, people started wondering, does your VTE risk increase? And so a lot of people have looked at this in the general population. There have been mixed results, but it looks like the patch may increase your risk for VTE. So now there's a black box warning. And our patients are the last people that need to be put on a medication increasing their risk of VTE. So the patch is a no-go from my perspective in our transplant population due to the increased exposure of ethinyl estradiol. Okay, how about the vaginal ring? So the Nuva ring is kind of this cool invention that it's a ring that you insert and all of the exposure is mostly local. And so this is really neat because there's lower ethinyl estradiol exposure than the patch or oral contraception using the ring. And I'll just orient you here. So the blue here is your systemic exposure to estrogen with the Nuva ring. The patch is right here, so it's more consistent, but much higher than the ring. And then your oral contraceptives, you get kind of that peak each day, and then it comes back down. So theoretically, the Nuva ring might be a great option. You do have that week where you take it out, but you probably don't have the drug interactions that you have with these other agents. And we actually have a study in transplant patients. It's just a retrospective observational study of 9 renal transplant and 8 liver transplant recipients, but they found no unintended pregnancies and no clinically relevant changes in blood pressure or heart rate with the low systemic estrogen exposure. They didn't comment on drug levels, but we've got one paper saying that we can use it in transplant patients. So I covered a bunch of estrogen containing options. Now, what about all of the options that don't have estrogen? So you totally avoid that drug interaction. Well, one of the options is the mini pill, norethindrone pills. The pros are you're avoiding the drug interactions. The con is that norethindrone has a really short half-life, 8 to 11 hours. That's a very short half-life for a drug that's dosed once a day. So adherence is super important with this medication. In fact, it's recommended to counsel patients to take it at the exact same time every day and to use a backup method if they're 3 hours late taking a dose. So if we think about some of our young female heart transplant recipients, they may not be the best candidate for this. We've got Depo-Provera, the once every 3-month injection. What I want you to take away from this is in the general population, I don't have transplant data for this one to present, but in the general population, it contributes to weight gain and bone loss. And those are 2 things our patients definitely don't need. So, I seem to have lost my Y and X axis, but you'll have to trust me on this. This was, again, a study in the general population. And they looked at, it was a 4-year prospective study, and they looked at patients when they were receiving the DMPA, and then after they stopped it, and they looked at their bone mineral density. There were 183 women that were receiving it right here. You can see that their bone mineral density was quite a bit lower than the 258 that did not receive the DMPA. And then once these patients stopped, it appears that their bone mineral density actually goes back to that of a non-user. But what we don't know are the long-term effects of this drug. So does it affect peak bone density down the road? Does it affect fracture risk down the road? And in the general population, the ACOGs recommended that this is, a good option for patients, that this risk likely, that the benefit of the efficacy of this contraception likely outweighs the risk of the effect on bone mineral density. But I think in our patients that are on a lot of prednisone, it's probably not the best option. And we know that patients gain weight. So this was a study on over 7,000 patients, general population, and they were randomized to either receive the DMPA injections, a levonorgestrel implant, or a copper IUD. And you can see here that over 18 months, they gained about 3.5 kilograms on average, which was significantly higher than the other options. This has been repeated in many studies in the general population. And one of the things that I think is interesting is that folks who, you can see here, BMI at 0 months is the same between groups, but those patients that gain more than 5% of their body weight within this first 6 months gain a significant amount of weight compared to those who don't. So I think the take-home message is this is probably not the best option for our patients. I don't think it's contraindicated, but if we're going to use it, we should make sure that we're monitoring their weight. And if they gain a lot of weight in that first 6-month period, we should take them off and switch them to a different agent. And my last agent that we have available that I'll cover is the Nexplanon, or the levonorgestrel implant, which works for about 3 years. Again, we're putting something in a transplant patient who's immunosuppressed. So the theoretical risk is that there could be increased infections at the site of insertion. And in 2001, we finally got our first study on the implant out of the University of Colorado. This is like a retrospective kind of case control study of 24 patients that were matched for age. They included 6 heart transplant recipients, and interestingly, 6 patients that were on mTOR inhibitors, and found no incidences of implant site infection or pregnancy. They did look at graft and infection outcomes, although I wouldn't have expected those to be different between groups. So just to wrap up contraception, I will tell you what my thoughts are. Of course, every patient's going to be different. You'll have to make a patient-specific decision. But my personal opinion is that the levonorgestrel IUD is the best option for our patients. It doesn't rely on adherence. It doesn't rely on them taking a pill every day. It relies on local exposure, so you don't even really get a significant systemic exposure of medications, and there's no drug interactions to worry about. The Nexplanon, the implant, I think would probably be my number 2 It also has a very low failure rate, does not rely on adherence, no drug interactions. So really, this could probably both be number one. They're great options. Number three would be the vaginal ring. So this has estrogen in it, but because it has such a low systemic absorption or exposure, you're probably not going to have the number of drug interactions or the degree of drug interactions that you would with other options. Although it does rely on monthly adherence, it only relies on someone putting in the ring one day during the month and then taking it out at the right time. And then I put combined oral contraceptives and our mini pills as both as number four, because it's really going to depend on your patient. We discussed the issues with estrogen. You can kind of get around that with continuous administration. So that's one option. You can also get around that using the mini pills or norethindrone pills, but strict adherence is required. So you have to pick your patient carefully with those. And then to answer our SJ's question, which option should she avoid? I would recommend avoiding the copper IUD due to the reports of treatment failure in transplant recipients, the patch due to the increased systemic estrogen exposure, and the progesterone injections due to the risk of bone loss and weight gain. And that is it for my portion. Anyone got any questions before we move on?
Stephanie, do we have a mechanism where you guys get involved routinely for this counseling, post-transplant or pre-transplant?
So part of Mabel's standard counseling when patients leave the hospital is on mycophenolate REMS. And that's pretty standard for most transplant centers. So that the counseling occurs then, but we're not starting patients on contraception at the time of discharge from their index admission. And so I've been seeing most of our patients that are new transplant patients in clinic, and the thought would be that once they're home and stable, I'm starting to have some of those discussions with those patients. And we found a few that are a little farther out from transplant that are now sexually active and may need contraception. And we've been referring them, but I think it is helpful when we can prep them with some ideas for some options that might be good for them.
Yeah, thank you.
Yeah.
Something that I just found over here is that in the general population, the failure of the copper IUD is 0.8%. So I don't know if the failure in these patients that you mentioned would be immunologic mediated or due to the immunosuppression, or it's just, I don't know if it would be comparable to the general population, because if it was just 2 cases.
Yeah, and that case report was, I think, like 1987 or something like that. I mean, the copper IUD has been used for a long time, so I don't know how many patients were using it at that time and what the failure rate would be, but that case report was enough to turn the entire transplant community off of copper IUDs. So it could be the failure rate of the general population, but we just don't know.
Well, thank you very much. I think we can now move on to our next speaker.
Sorry, one second. I just want to make sure you guys can hear me and see my screen.
We can hear you and we can see your screen.
Excellent. So good afternoon. Thank you for the introductions earlier in the presentation. I also have one of my colleagues, Kathy Sumpio, here with me. She works in oncology and is our patient education specialist. Just to help out with any questions that we have. I think it's a really, the presentation that precedes me was helpful because we're talking about some of the similar medications. The reason I was asked to come here to talk about this was that there were some patient concerns after receiving some information on hazardous handling of a medication that you wouldn't typically consider hazardous. And this does not surprise me at all, given the current environment that we're in regards to safe handling from a regulatory perspective. So my presentation today is on the United States Pharmacopoeia's Chapter 800, which addresses safe hazardous medication handling. I'm going to give you a quick review of what the chapter discusses as in regards to hazardous handling, describe some of the classifications for medications that fall into the hazardous category. That list is much larger than what we've seen in the past or discussed and addressed in healthcare. Along with describe some of the measures that we've taken from the Yale New Haven health system to ensure minimal exposures for employees and ultimately to patients. And lastly, get into some of the information that we're going to be providing to patients moving forward. You are all the first to hear this presentation. As far as Yale New Haven Health goes, our program is rolling out over the summer. So will be new information for everyone. To give you the background on United States Pharmacopoeia, I essentially think it's an organization that gives us the recipe for being pharmacists. Its overall role is to recognize and put together the public standards for quality of medications. Its overall goals are quality and safety in regards to medication. There are several chapters that address important impactors for the pharmacy, the type of pharmacy that we practice in hospital settings and in the community settings. Those are listed here. It's an enforceable guidance document, and it's enforceable through the Food, Drug, and Cosmetic Act of 1938. The chapter was actually published back in 2016, which is what, 8 years ago, or 6 years ago, I'm doing my math terribly. However, it wasn't going to be enforced until 2019, give institutions time to prepare for what it was calling for. However, there's some bylaws with the United States Pharmacopoeia that enforce that chapters are not enforced until they're referenced from a previous chapter. And then the unfortunate circumstances are that chapter 797 is the one that references it. So 800 is in a kind of flux area of enforceability, for lack of a better word. But states are starting to require that hospitals, institutions, community pharmacies enforce it because it does address a safety issue for employees. So OSHA is not waiting for enforceability. It would be something that they would look for if they came to visit any of our institutions. From the state level, Connecticut Department of Consumer Protection comes in and would review hospitals. They'd look at infusion centers and even patient-specific compounders. The FDA looks for compliance in this on these guidances for manufacturers. And it's important to understand that the accrediting institutions like Joint Commission and URAC that are out there, they're looking for compliance today, even though it's not necessarily enforceable, or what they refer to it as compendally applicable. A little background, we've known that hazardous medications are a risk, an occupational risk since 1960. It wasn't until 1970 that OSHA really drew the link with studies and started to publish it and make it common knowledge. In the 80s, our Oncology Nursing Society published its first safe guidance document. It was also the first time a hospital was cited for not protecting employees. It wasn't until 2004 that we had NIOSH published. NIOSH has since published 3 different drafts of its list. And essentially NIOSH gives us a list of hazardous drugs based off of monographs, drug safety efficacy studies. And in 2016 is when the United States Pharmacopoeia put out the guidance that really ensures appropriate practices within pharmacy. The goal of it is protect people, environment. It pertains to anyone that handles medication in any activity. So anything from handling all the way to dispensing and administering. An important point is that they point to NIOSH as the reference document for hazardous medication. So any medication that falls into onto the NIOSH's drug list would be something that you'd have to consider the special handling guidance that USP requires. So NIOSH maintains a list of anti-neoplastics, but also medications that cover other areas. And I think that traditionally, hazardous has been a synonym for chemotherapies. Our hazardous medication compounding area at Yale New Haven Hospital is on the oncology floor. It's an oncology area, but that's not the case. And especially when this guidance is fully enforceable and fully rolled out, hazardous is not synonymous with chemotherapy anymore. So an important point is, but everything that goes on the NIOSH list is based off of patient safety and efficacy studies. It doesn't address the type of exposures that we have as healthcare employees when we're handling them and manipulating them. So I already mentioned NIOSH covers not only carcinogen drugs that are carcinogenic, but it also has on it drugs that are teratogenic, have reproductive toxicity, just like Stephanie talked about, organ toxicities, genotoxic, and those that have structure or toxicity profiles that are similar to other drugs that have been already classified as hazardous. This helps us to make a determination of what we put on our list moving forward. You've probably all seen this. It helps me to conceptualize how I thought about this when I first saw the hazardous requirements, hazardous handling requirements. In healthcare, we can't necessarily take the two top actions in order to eliminate risk to healthcare employees. We can't eliminate our patients need these medications. We can't substitute because they're probably part of a regimen that we know has efficacy. So it's really at the level of engineering controls, administrative controls, and PPE that we take our action as healthcare to give guidance for healthcare employees. In 2016, as soon as this was published, Yale put money to the plan, and we started the development of pharmacy clean rooms that were conducive to appropriate handling for the pharmacy. It's now this month and moving forward that we're going to be rolling out the standard operating procedures and the PPE requirements as they pertain. And an important point to all of this is that in the guidance, it allows for us to take the NIOSH list, anything that we might consider hazardous, and do an assessment of risk. And that allows us to not necessarily apply every containment strategy that's required through the chapter, but to put a subgroup of other containment strategies that may help, but address things that are different than what you need for something that might be anti-neoplastic. And you do this by reviewing the drug, the particular type of drug, the drug form, its risk of exposure, the packaging, and the type of manipulation. And this is the approach we took at Yale New Haven Health. And we divided what we found. We review every medication that goes onto formulary and any medication that comes out on the NIOSH list. And we put them into two different categories. Category one being anything that is anti-neoplastic, carcinogenic, genotoxic, or mutagenic. And for these particular medications, we're applying everything that is written in USP 800 as far as containment. The category two covers the less harmful, quote unquote, harmful hazardous medications. Some, if it's anti-neoplastic, but in a formulation that we can easily pass it on to a patient, or if it's immunosuppressive, biologic, hormonal, or antiviral, but it has some element to it that has some toxicity, it might just be PPE that we require. So essentially we have three categories, because you have your non-hazardous within the health system, and our category two being a lower risk than category one. We applied it to every action you take with medications from the point of receiving it all the way to administration and handling. which is why our patients are now receiving information in regards to special handling for medications that fell into this list. I wanted to share with you some of the medications that have made it into the different categories. This one not being as surprising as category 2. This is, a lot of these medications you probably have already heard of as being hazardous, but the category 2 drugs are those that might be more surprising. I know that I believe that the drug that we first started this conversation about was spirolactone or tacrolimus. These are drugs that probably have black box warnings and are communicated out into the public. If you do a Google search, you're going to see that there's some hazards around them, but wouldn't traditionally be classified as hazardous to the general public. But it's important to note that they are now, as we roll this out, there will be different practices in the handling of these particular drugs and more. This is just a sampling of what they I put together for this presentation. To wrap it up, I know we're close to, we're over in time. We essentially are rolling out our standard operating procedures that we've developed over the summer and rolling out education. You're one of the first groups to hear anything about this from the standpoint of the health system. We're upgrading our information technology so that we have alerts and labeling that appropriately address this, along with redesigning some of the patient information based off of some of the feedback we got from this group in particular, looking at some of maybe stratifying the alerts that we send out to the patients to make sure that category 1 doesn't receive the same alerts as category 2 and vice versa. And our goal is to go live in the fall of 2022. And I think we have a pretty small group at this point because we're we've ended. I'm sorry, we went over. I don't even know if we have.
Yes, I think that many people end up joining all the meetings that they had. I know there was a structural multidisciplinary conference that just started a few minutes ago. So, and I think someone else had to go to a quality improvement meeting or something like that.
Great. So I hope that they got some of the points of the discussion. I know that there was a direct purpose for it, but again, like I said, this isn't going to be the last of our educations. We're just rolling this out and did it at a special request earlier than we're rolling out to everyone else.
Thank you, Gina. I think it's super helpful for us to know what information patients are receiving. I think that's how this ended up coming to be. So I don't know what information you have available, but it might be worth sharing that information in an email format, just in terms of what patients receive and what we could expect to get questions on. And I'm more than happy to distribute that to some of these folks if that would be helpful.
Thank you, Stephanie. I think that one of the things that we want to do is take another look at the way that we categorize and stratify what information is going to which patients, because there should be a difference between what we are classifying as category 2 versus category 1. So we do want to take another look at it. And when that's completed, we'll definitely share it with you. I'll be reaching out.
That sounds perfect. We definitely have those patients that toss all information given to them and those that read it thoroughly. So it's good to know what they'll be getting.
I think in the community, this information is being distributed already.
Okay.
And I think it's because it's probably been in the patient information for years, but in small print. And now it's just ours is more, we're being very transparent. We're trying to get information out to everyone. But hopefully this will be helpful once the patient's out there, more people will understand what's going on.
Gotcha.
And Stephanie, specifically, we made the handout to really be mindful of in the caregiver situation more so than the patient information and to give them safe handling instructions. But the very last section had other additional safety instructions for infusional medication that have traditionally been safe handling for chemotherapy infusions, antineoplastics. So we're probably going to take that out and just keep the patient and caregiver focus on handling the medications and handling any secretions in the event that there's exposure.
Okay, wonderful. Thank you. And yeah, once you guys recategorize and figure out exactly what's going to go out for which medications, I think it'd be helpful because Mabel and I do a lot of counseling on caregivers filling pill boxes and things like that. And so it may be helpful to have either copies of that or just make sure that what we're seeing is a direct reflection of what's in the paperwork.
Thank you. We'll probably have you review the draft.
Sounds good.
Thank you.
Thank you.
Thanks.
Have a great afternoon.